Hello, hello. Can you get me a paper towel, please?
Yep.
Welcome, welcome, welcome. It's Dr. Torrance. I'm here to do a fantastic presentation on how to relieve knee pain. We're with Regenix at New Regeneration Orthopedics of Florida, serving Sarasota, Tampa, St. Pete, and Orlando.
Then you're gonna be doing booster on the mouth.
Second, one second. I'll pause it. Hold on. All right, waiting for my esteemed colleagues. Should be on shortly. Again, this is Regenexx and New Regeneration Orthopedics, how to relieve knee pain. And we are serving Sarasota, Tampa, St. Pete, and Orlando. Now, we do serve other people from other states for medical vacations to come and get better, but that is an exception. And Dr. Lieber's here. All right. Dr. Lieber, can you hear me?
Yes, I can.
All right. Your camera's not on yet, just an FYI. All right. We are we're waiting on Dr. Zakis to get in here. We are Regenexx and New Regeneration Orthopedics. This is our How to Relieve Knee Pain webinar, and we serve Sarasota, Tampa, St. Pete, and Orlando. I'm waiting for, if you want to leave a, second. Dr. Lieber, do you want to start us and then I'll get Dr. Zakis in here?
Yeah, that's fine.
Okay.
Thank you.
All right. So I'll let Dr. Lieber lead the way here on our knee pain webinar. Dr. Lieber.
All right, thanks. So we are Regenix at New Regeneration Orthopedics of Florida. We're made up of 5 physicians that are listed here: Dr. Torrance, myself, Dr. Lieber, Dr. Pappas, Dr. Velastro, and Dr. Zakis. We have 4 facilities, currently Sarasota, Tampa, St. Pete, and Orlando. And let's go on to the next slide. So today we're talking about knee pain. And so there's a lot of different ways that physicians will approach pain and how people themselves will approach knee pain. So if you have knee pain, whether it's from an injury or from chronic pain of some sort, from arthritis, for example, you'll tend to just sort of manage it on your own for a little while, do the best you can with over-the-counter medications, rest, ice, maybe bracing. See a physician if that's not working, and or a provider, and they may recommend various different options to you. One may be a cortisone injection, which is what this slide is about, and this is showing that putting cortisone into a knee compared to a sham injection with saline, found that the actual cartilage in the knee will wear away faster with the cortisone. We know that cortisone is damaging the tissue all over the body, and in fact is also damaging the tissue in the joint, including wearing away of cartilage, wearing away of bone, and likely makes you more likely to need a knee replacement down the line with that strategy. So one of our goals is to keep people from needing to have these cortisone injections because we just know that it's the wrong thing to do for most conditions for the knee. Go ahead and go to the next slide. And this is just basically a study affirming what I mentioned regarding putting cortisone in the knee will increase the risk of needing a knee arthroplasty, which is a joint replacement. Let's go to the next slide. So basically, I've already said this, cortisone may accelerate the progression of osteoarthritis, meaning wearing away the cartilage, increasing the arthritis in the joint. Even though it gives some pain relief initially for most people, it's short term and it's a trade-off where you're actually going to make the knee less healthy in the long run. Um, we do have people who are on these cycles of every 2, 3 months or every 6 months cortisone injections. There's this mantra in the orthopedic world, which I also learned early in my career, which is it's okay to give cortisone 3 times in each joint in the course of a year, which is not based on any research. We dug into that at one point in the training program I was in and found that that was just basically dogma. And in fact, the opposite is true. Cortisone, even 1 time, and certainly multiple times, will accelerate arthritis and weaken tendons and bone and so forth. Let's go to the next slide. This was looking at 3,800 patients. This was called the Osteoarthritis Initiative Database. It looked at these patients over the course of 9 years. Go to the next slide. And they gave steroid injections and tracked these patients versus those who did not get steroid injections, tracked them over 9 years. And 33% of the ones who got the steroid injection ended up needing a joint replacement in that period of time. And the ones who did not get the steroid injection, only 5%. And they were matched groups. In other words, they were similar in both groups of the study. Let's go to the next slide. I think we're beating this dead horse here. What about meniscus tears? So it's super common surgery. It's been for many, many years and still is, maybe slightly less so common to get meniscus tears in quotes repaired surgically. So there are issues associated with that as well. Let's go to the next slide. So this is often done through arthroscopic meniscectomy, which is basically putting a scope and tools into the joint. And this one is describing the actual snipping away of unhealthy meniscus tissue, which is a common practice and occurs in most of these surgeries related to the meniscus. However, it has questionable utility compared to doing non-surgical treatments for the same issue. Let's go to the next slide. So this was a study looking at doing this kind of snipping away of the meniscus tissue versus doing a sham surgery or a fake surgery. In other words, they go in to the knee but don't do anything at that time, and then compared these two groups of people to see what their outcomes, and found that the fake surgery did just as well than the actual real surgery, without the consequences associated with the real surgery, which is the pain associated with the procedure, but then also the long-term risk of developing accelerated arthritis and needing a joint replacement. So, what is the point of doing that surgery if it's just going to make things worse and is no better than doing no surgery? That's what this study and many actually have shown at this time. Let's go to the next slide. Let's see. This is a study that's entitled Arthroscopic Surgery for Degenerative Knee. And this was what's called a systematic review and meta-analysis. So looking at a whole accumulation of different studies put together into one statistical analysis. And they found, again, same sort of thing. If you go into these knees and do debridements, which is basically cleaning, they call them the clean outs, where they shave away. Hi, Dr. Zakis, thanks for joining. Uh, they shave away unhealthy appearing cartilage, for example, or frayed looking cartilage, and then track these patients over time and find that it actually did not help in the outcomes. And again, we have other data to show that it actually will accelerate the likelihood of someone needing to get a knee replacement. Next slide. Yeah. So, problem with knee replacements. So, we all know people who have done very well with knee replacements, but in our profession, we also see lots of people who have not done well with knee replacements, and that just depends on your circle of people. We just have a larger group that we see. There are serious complications that can occur and do occur, including infection, including blood clots, and but very significantly, within the first 6 weeks of having a joint replacement, especially in the older group, there's a very significant increase of heart attacks or strokes in that time period compared to not having the surgery at all. Um, so I don't think that gets mentioned enough. And then you have things like continued pain. So if you're going to go through such a major surgery, you would hope and expect that you're going to be have limited or no pain afterwards. But there's a fair amount of people who continue to have pain after a joint replacement, which is a shame. And at that point, there are very little options for them, either a replacement again, which is a bigger surgery if there's some reason for that. Otherwise, it's what we call pain management. The only way to manage that would be with pain medications. Other things can occur, like allergy to metals and potentially dislocations and leg length changes. That's fairly common, actually. Let's go on to the next slide. So I don't know if anyone else wants to jump in here and talk a little bit about what we refer to as regenerative medicine or regenerative orthopedics.
I'll take it unless Dr. Zakis wants to go. All right. So what is regenerative orthopedics? Regenerative orthopedics is using the body's own cells to help the body heal itself, make itself better. And we really focus on tendons, ligaments, muscles, joints, cartilage, and nerves. And this is a study that looks at PRP and a survivorship study on PRP for knee arthritis and how many people could avoid a knee replacement years in the future after having PRP successfully once a year by Dr. Mikel Sanchez et al. And the finding was that the people who had PRP had more knee joints that survived. So there, henceforth, we had more people avoid knee replacements. So that was one of the studies. This was a retrospective study, again, by Dr. Mikel Sanchez et al. From 2014 to 2019 that had 85.7% in follow-up have less knee replacements, more survivorship in the knees. So again, PRP can help delay knee replacement. Now, what else do we have in our repertoire to really help with knee replacements or more moderate to severe arthritis. In mild to moderate, we know that PRP is usually the recommended injectate, something that really can help delay the need for knee replacement. But mild to moderate arthritis shouldn't really necessarily need knee replacement. Moderate to severe arthritis is something that usually comes concurrently with some edema in the bone. And this study by Dr. Felipe Hernigau discussed how injecting into the bone, thinking outside the box type concept, could delay the need for knee replacement. Into the bone, what does that even mean? Well, just like I like to think of bread, right? In bread, you can see how when you put on jelly, the jelly essentially seeps into the bread. And that's really what the bone looks like inside your body. So by injecting your body's own bone marrow derived stem cells into the bone itself in these edematous areas that usually are causing the pain for knee arthritis, we can help delay knee replacement. And this study went out 15 years, and 80% of patients avoided a knee replacement 15 years later. So this is really kind of a good infographic on what that looks like. This side over here was the injection into the joint itself. The one over here was actually injecting the bone by itself. When we do our procedures, we inject not only into the bone, but we also inject the ligaments and structures surrounding the bone to help stabilize these the looseness in people's knees, some of the laxity, some of the, I like to call it this stretched out drawer mentality. You got some stretched out ligaments. It's been a little bit of time. You've been moving around on these knees, and anybody knows that you put something into a loose bag, you put some sunglasses into a loose bag, and if you run around and make your day, you're going to have scratched up glasses. Well, same thing here. You're going to have scratched up cartilage if your knee's really loose, and that cartilage gets broken down, and that leads to more arthritis and more degenerative change. So this is what edema looks like on an MRI, and this was really just kind of more details on the study that we were talking about, how injecting into the knee, the bone itself, can help delay knee replacement. And this is a follow-up MRI 2 years later after injecting into the bone, demonstrating that we can get changes on MRI that show that the inflammation or the edema in the bone is resolved. And again, this showed that about 18% of the 140 patients only underwent a knee replacement. So 82% avoided a knee replacement. So we'll take questions now, talking about the things we do or any of the questions about knees, and we will open that to anybody here today. Dr. Zakis, I think Dr. Pappas got hung up with a patient, so he's not going to be able to make it. And unfortunately, Dr. Vlasher couldn't make it today at all either. So, but we will take some questions, put them in the chat box. We usually take a good number of questions, try to explain things.
Don't be shy.
So I'll ask Dr. Lieber this. So what, I heard that some of this, we have corporate clients. Could you explain, Dr. Lieber, what corporate clients are to the audience?
Yeah, so I think a lot of people expect that this kind of the procedures we do are paid out of pocket, self-pay, and it is for a good portion of people. But there are a lot of people now who are getting coverage for Regenexx procedures. Regenexx has contracts with organizations throughout the country, including quite a few in our area. Some are companies, some are cities, some are school districts, religious organizations, so forth, that have taken on Regenexx as a benefit for their employees. And the reason they've done this is because they've been able to collect sufficient data to show that surgeries are prevented and therefore costs are saved for their employees. These are generally going to be companies, we call them corporate clients, but these are companies or organizations that are self-insured. In other words, they pay for their own all the procedures. So if a patient has a knee replacement, the actual cost of that comes out of the funds of that company. So so that's called self-funded, self-insured. So they're very incentivized to try and save money. And so they add these kind of wellness programs into their benefits package. And so locally here in Sarasota, we have like the Sarasota Sheriff's Department, and recently the City of Venice, and various different large organizations that are local or even national or even international. So we're glad to work with these organizations and be able to offer this as a benefit for them.
All right, great answer. Next question is, what if you've already had a knee replacement but are still having pain? So this is a very frequent issue that comes into our office. We do diagnostic ultrasound on all of our knees or anybody who comes in with knee pain, even if it is an arthritic joint. And a lot of times we're able to help those patients because the joint is replaced in knee arthritis. However, the ligaments and some of the tendons are not replaced. And those can be very, very symptomatic in certain cases. And those can be they can respond very well in certain cases for certain issues. So come in for a consult. We can probably try to help you out. If we can't help you out, we'll let you know, and then we'll send you back to your knee surgeon. Next question, Dr. Lieber. Let's answer this one. Full tear of the meniscus with very little arthritis. What do you recommend?
Full tear of the meniscus, I see. Unless someone is having significant locking, meaning they can't bend or straighten their knee, Um, uh, we generally am not going to be recommending that for surgery, at least not as a first step. We have seen this many, many times, and people can do very, very well with typically bone marrow directed injections into that meniscus for larger tears like that. It's never going to look normal again, but it can become more functional and less painful, and generally are able to avoid that surgery. Again, if it's locking significantly. Even mild locking will treat that and catching. He mentioned here, I see that you wrote no locking. So at this point, I would not say that I would favor referring you for a surgical procedure for that.
Great answer, Dr. Lieber. And I think the first thing that I like to tell patients is that you got to come in for a consult and let us take a look at the knee with that ultrasound to look at that meniscus. A full tear, there's a lot of different types of tears, and no locking is really the biggest thing, like Dr. Lieber said. But I think looking at the knee will be a good telltale sign too.
He's asking if PRP can help. It can, less consistent and, may need more than one treatment as compared to a bone marrow treatment, but it's not unreasonable to start with a PRP and direct it into that tear and see if that's going to work. But it wouldn't be, our primary recommendation, but we certainly can consider that.
Oh, this is a good one, Dr. Lieber. Do you want to go into this one? All right. So PRP can possibly help, but we would probably we would probably say that bone marrow concentrate is going to be better. The fibrocartilage, I think Dr. Lieber told me this when I first was starting, that fibrocartilage responds a little bit better with bone marrow concentrate, probably a little bit more than a little in practice now for 8+ years. So, Dr. Lieber, do you want to talk about umbilical cord derived exosomes rather than stem cells?
He says, why not use them? I guess the better question is why use them? So research wise, there's a whole host of things here. We have to talk about this a lot with people because it comes up so often. I think I lost the question, but I think I recall what it is. So there it is. So basically, a couple of things. Exosomes. I had this long conversation with a dentist friend of mine just this past weekend. He was texting me all about exosomes, umbilical cord, and I had to clarify for him the legalities associated with this. Again, it's just confusing. It's what's confusing is people are using it, so the assumption is that it's good and that it's actually effective and legal. The problem is federally, the FDA has made very clear that exosomes used for orthopedic injections are considered to be a drug, and they can only be used in the context of an approved clinical trial. But outside of that, it's not legal to use them. So that's one. The same thing goes with umbilical cord stem cells. Those are not legal to use for orthopedic conditions federally, as opposed to in the state of Florida. There's been a new recent law that's passed that kind of is in opposition to the federal law. So there's some confusion about it there. But umbilical stem cells, the other problem with umbilical stem cells is that the products that are on the market that are sold to physicians, when they're tested by independent academic laboratories, they find that they don't have living stem cells in them as they claim to. So there's some issues with what's in them. There's issues with the legality of using them. And then, very importantly, there's very few there's very little research to support their use. So for us medically, we want to be using things that we know make the most sense and have the best research evidence associated with it. So there's a whole host of issues associated with using those. If they work great and there was great research and it was legal, we'd be happy to use them. But that's not the state of things at this time. And you will hear different things from maybe a chiropractor hires a nurse practitioner to do the injections. They're basically working with these marketing teams that work with these manufacturers who collect these cells from hospitals. And really, this is truly an organized crime network around the country, and there are multiple organizations who are involved in this. But we just try and keep our head above the water, make sure we color inside the lines. This is not something we should be using at this time.
I concur, Dr. Lieber. And if you follow anybody on LinkedIn, like Don Buford and Dr. Centeno, and or Dr. Lieber and myself, there are tons of FDA letters that are being sent out federally. This is not accepted and not allowed. And the people in Florida who are trying to get around this are getting federal letters. So you can't get away from the federal mandates, which tell us that we shouldn't be using these products because they're not tested. They're not shown to be effective. They're really just very well marketed. And like Dr. Lieber said. So, all right, let's take the next question. And Dr. Lieber and I don't look good in orange jumpsuits.
Speak for yourself.
Oh, you look good in orange? I'm trying to get the next question. Sorry. Here we go. Okay, we could take. It's been 4 months since my stem cells procedure have improved by 40% improvement. Should I expect more improvement over time? I'm still getting PT. Yes. Yes, that's my patient. Yes, you should expect more improvement here, usually up to 6 months to a year. And also understand that UK, they are conducting research on regenerating cartilage. Can you comment on this type of study and its further implications? I think you're talking about the German stem cells or the German gel shots. You have to send me the article, Sal, and I'm happy to get back to you on that. But I made a post about this because there are these really great, well-marketed, amazing AI-derived injection videos about like looking like cartilage is healing and all that kind of stuff. If it's out there and it's worth it, and we see the studies that show it, Dr. Lieber, myself, Dr. Zakis, Dr. Pappas, and Dr. Vlasher, we will definitely do it to help our patients. But we follow evidence-based protocols to make sure that our patients get the best injections possible and the best outcomes possible. And I hope that it continues to get better for you. Can you do a Zoom on neck pain? Absolutely. I think that's on our to-do list. Maybe we'll get that for our next one. And then do you ever inject directly into a torn lateral meniscus versus the joint space? And Dr. Lieber, you want to take that?
Yeah, I was actually in the middle of typing, but I'll just say it to him. The answer is yes, definitely. That would be preferred. So the key is, and where the skill comes in, is these kind of very precise image guided injections. We really need to get the needle into the tissue that we're trying to impact. This idea that you can inject near it or stick it in an arm or a leg, and it goes where it's supposed, they know where to go, is what are being told in some of the marketing campaigns. That's not really the case. You really have to get the needle right into it. So if you have a torn meniscus, then we want to get that needle right into that tear and put the material there. So that's the best place for it to be.
I think Dr. Lieber and I both agree on this, that there are a lot of yahoos out there saying that they can do all these injections, but everything that we hear is people coming in going, I got one injection and I drew 2 tubes of blood, or they didn't do, they got it from on the shelf or something along those lines. And it's just, if you're not going to see a physician who's been trained by the IOF or a group similar to that, like the AAOM, I don't think that those injections are going to be precisely placed in the right places. So that's I concur. All right. Well, we have to get back to patient care. Thank you, everybody. If you have any other questions, please leave them. Would you think of mixing in Arthur's Infertil with stem cells for healing a torn meniscus? I don't know what that is.
I don't know what that is either. Probably need a little bit more info and
Clarification. Yeah, so shoot us over. We're all open. info@regentampabay.com. We'll make sure we get the email and get you an answer back. But thank you guys for coming today. Sarasota, Tampa, St. Pete, and Orlando. Schedule your appointment. If you don't follow us on the socials, follow us on the socials. Other than that, everybody have a great day.
Okay, take care, everybody. Thanks. Bye-bye.